Hello everyone. Today let's start Anesthesia INICET 2021 paper. First question. A 42-year-old man who was under home isolation after testing positive for COVID-19 develops breathing difficulty and is brought to the emergency room. The patient is alert and responsive but is breathing rapidly. SpO2 is measured 86%. He is administered oxygen via face mask with a reservoir bag with a flow rate of 10 liters per minute. After a trial of 1 hour, his SpO2 is just 88. See, 86 to just 2% is increased. What is the next step in management? Increase the flow rate to 15 liters per minute. No. High flow nasal cannula oxygen therapy. Yes, this is best actually. Endotracheal intubation. No, because just you have tried only 1 hour. When you have a better options, why you just and skip for a invasive procedure, isn't it? So, endotracheal tube intubation is done after failing of the high flow nasal cannula oxygen therapy. No specific intervention necessary. No intervention is obviously needed. He is already rapidly breathing and he is alert and responsive. But if you don't intervene, he might end up his life. Yes. So let's see. The patient has a persistent hypoxia. Yes, we can see that. After the adequate trial of standard oxygen therapy, we have used oxygen non-breathing mask. Oxygen therapy we have given. Should start on high flow nasal cannula oxygen therapy, and you have to closely monitor if patient acutely deteriorates or he doesn't improve after short trial, that is after 1 hour also, you can then intubate. Okay, so here the option is B. This 2021 they have asked in all the papers, anatomy, physio, everything. If you take, they have asked more about the COVID-19 questions. Okay, what is the frequency of tetanic stimulation used in neuromuscular monitoring? Actually, this is also one type of bouncer question. The tetanic stimulations we will not use now. We will use the trial of 4 technique to see the neuromuscular monitoring. Tetanic stimulation is a method to evaluate residual neuromuscular blockade. If any, after giving anesthesia also, if there is any residual blockage or the reversal is complete, we can see by this. The commonly used frequency in tetanic stimulation is 50 Hz over 5 seconds. So here the option is 50 Hz. Okay. Okay, third one. You are in the operating room and notice the tracing in the yellow color. This one. What does it indicate? This is the yellow line. Is nothing but a capnography. Okay. Let's see. The yellow in the monitor is the capnography. It is a direct measure of the lung ventilation and indirect measure of the circulation and metabolism also. Okay. And tidal CO2, surest confirmation can be done by capnography. This is the capnography. Okay. It is a measure of carbon dioxide, isn't it? So first phase is 0. From here to here, it's 0. That means what? It is declining, isn't it? See, it is actually 0 also. That means here the carbon dioxide level is low. That means you are inspirating. That means you are taking in the oxygen, hence carbon dioxide is low. So is inspiratory downstroke. One is inspiratory baseline, that is the dead space. Okay, here the from 2 you start the expiratory upstroke will come here. There. Here the in second one there is mixture of the dead space and alveolar gas. Dead space and alveolar gas. Whereas in third one there is alveolar gas plateau will come. This is the alpha angle, that is the transition from phase 2 to phase 3. Whereas beta is the transition from 3 to 0. Sometimes 0 is also called as fourth phase. Okay. Here there are different patterns. This you can see the steep in the phase 2, This is the bronchospasm. This is the sharp fin pattern. Whereas this is the full expiration is not taking place, isn't it? It has to come 0, isn't it? Here the expiratory wall malfunction is present. Here you can see the inspiratory wall malfunction. Yes. This is actually a physiological in pregnancy when subjected to general anesthesia. The crural cleft is seen when there is a insufficient muscle relaxant is given, the patient is spontaneously breathing. Okay, that time the crural cleft will form. Here the patient is rebreathing the same expired carbon dioxide, hence this is not touching the baseline. There is esophageal ventilation. This is also a spontaneous breathing is present, okay? But they will ask this only. This is one side dip is present, isn't it? So this is a single lung transplant. And this upstroke is for malignant hyperthermia. This is also their favorite. Here you can see intermittent mechanical ventilation. Mediate the spontaneous breathing is also present. This is during cardiopulmonary resuscitation. This is the cardiac oscillations. This is present in thin chest in pediatric age groups. This contamination of the sensor or soda line exhaustion. Okay. This is also a rebreathing in inspiration. Okay. One thing I'll tell. If first there was a normal graph and next sudden collapse, what it might be? It might be CO2 embolism, or sometimes there is a disconnection in the EtCO2 mission. Okay. So here option is A. Fourth one, 50-year-old male patient has a grade 3 ASA. Which of the following post bronchodilator pulmonary function test finding requires further evaluation of the lung function of this patient? What is ASA? That means American Society of Anesthesiology. PFT means pulmonary function test. Okay. So here the in option FEV1 means post expiratory volume in 1 second, that is first second, whereas this FVC is post vital capacity. This they have given a COPD patient. Okay. Which of these requires further evaluation? They are asking. FEV1 and FVC should be less than 0.7 is considered as a COPD. Okay, let me show you the explanation. See, the Global Initiative of Chronic Obstructive Lung Disease goal system categorizes airflow limitations in the stages. When you give a bronchodilators, the post bronchodilator EV1 by FVC ratio should be more than 0.7. But if it is less than 0.7 even after giving a bronchodilators, that means it is not responding to the bronchodilators, then we can consider it as a COPD. But to consider it is mild, moderate, severe, very severe, we have to see the first second how much is the forced expiratory volume. If it is more than 80% predicted, then it is mild COPD. Whereas in goal 2 there is moderate, that is less than 80% but more than 50%, that means it is a moderate. Whereas less than 50% more than 30%, then it is severe. Whereas less than 30%, that is very severe. From this moderate COPD, you have to do other lung function test. Okay, here they have asked same question where you have to do a further testing. So if V1 by FVC is less than 7, only one option is given, that is C. But you can see it is less than 80%, that is 0.8 means 80%. Less than 80% means it is a moderate. Mild means more than 80%, isn't it? 80% predicted. Here moderate is this option C. Coming to the fifth one, the 60-year-old male patient was undergoing laparoscopic cholecystectomy. During the surgery, the sudden drop in EtCO2 to 8 mm of Hg was noted. His SpO2 became 90%. His blood pressure dropped to 80 by 50 mm of Hg. Peak airway pressure was 18 centimeter of water. What is the diagnosis? This was the question I was speaking about. The sudden drop in EtCO2. What is that? Carbon dioxide embolism. Along with this hypotension also. See, when there is hypotension also, there can't be the disconnection in the monitor, right? It should be something carbon dioxide embolism. So only option 1. Why not other options? Let me show you the explanation. If there is a bronchospasm, there will be increased peak airway pressure. Along with this is sharp fin pattern. In pneumothorax, there is hypercapnia along with hypoxemia will be there. Hypotension also will be there, but increased peak expiratory pressure. It may lead to abrupt cardiovascular collapse. Single bronchus intubation, there you can see just absence of breath sound over one lung, and also the generally during intubation the ET tube will go to a right lung. Okay, the airway pressure will be increased and there will be asymmetric chest expansion. So you can rule out every other option, where in all the options the mainly the peak airway pressure will be increased. Sixth one, ventilator support is required if the SpO2 becomes less than 90%, because yes, it is because the tissue becomes vulnerable for the hypoxia below 90%. Yes, the peripheral chemoreceptor becomes insensitive to hypoxia. No, they are sensitive to hypoxia. Yes, central chemoreceptors also becomes sensitive to hypoxia. The patient capacity to generate adequate tidal volume decreases below 90%? No. When SpO2 falls below 90%, the partial pressure of the oxygen becomes less than 60%. Hence, the tissue becomes vulnerable to hypoxia and supplemental oxygen therapy should be started. Okay. Seventh one, how long should elective surgery defer for a patient who had cough and fever after he has recovered from COVID-19 and had not required any hospitalization? It is 6 weeks. Okay. Here they are asking the patient is having some symptoms and how long he should wait for conducting a surgery. How much long he has to wait? It is 6 weeks. See, if patient is COVID positive but he is asymptomatic, then he can wait for 4 weeks. But if he is symptomatic and does not require any hospitalization, then he can wait 6 weeks. Where the patient who is hospitalized or of the patient who has comorbidity, you can wait for 8 to 10 weeks. But if patient who is admitted in ICU settings, then you have to wait for 12 weeks. Okay. Here, eighth one. What is the nerve blocked in the following local anesthesia technique? This is the medial side of the eyebrow. Here, which nerve will come? It is the infratrochlear nerve, which is a branch of nasociliary nerve. So, option A. The medial end of the eyebrow, infratrochlear, continuation of nasociliary nerve. Whereas this point just lateral to the medial end of the medial epicanthus. Here, the anterior ethmoidal block can be given. Whereas here, this side, the infraorbital block, it is a branch of maxillary nerve. Here we will do nasolacrimal duct patency can be checked. Whereas here near the nose, here external nasal branch of anterior ethmoidal nerve, which is a branch of nasociliary nerve. Yes. Here ophthalmic nerve, which comes in the superior orbital fissure, lacrimal, frontal, and nasociliary. Nasociliary again divides into infratrochlear and anterior ethmoidal. Anterior ethmoidal is the internal nasal branch and external nasal branch, which supplies to the tip and dorsal root of the nose. Yes, this one. And it will give a posterior ethmoidal branch also. Hence, here option is nasociliary nerve.